Yeah, but it's.
Silence it.
We are live.
Okay.
It's more about
I think I'm thinking.
Yes.
It's famous. It's a one word.
I could maybe start a new.
It's like
right. That's the very bottom of my purse. Like, seriously, and now I got to do this. And he's like, sorry, bear with us just a moment here. There we go. Oh, okay. Okay, sure. Okay, good morning. Can those of you on the Zoom call hear us?
Cora Parakoff says he can't connect.
We've just sent an updated Zoom link within the last, we're getting people joining right now. So if he could just maybe check his email again, we have to refresh that. Thank you, Representative Claire. Okay, great. I've got a response from Elizabeth Wall that she can hear us. We'll just start in a few minutes. I want to give people an opportunity, since we just sent out that updated link, to jump on. So if you wouldn't mind just bearing with us a couple more minutes here, we'll still start 20 minutes earlier than we did last time. So. It's 9 a.m. Friday. You.
Let me know if you don't see it.
Great. All right. Well, acknowledging that we may have a few others join us as we get going here, but in the interest of time, we'll get started. If you hear from others who are trying to join, please ask them to check their email as we just sent out an updated Zoom link. Had some issues with the link itself. So looks like we've got a fair number of people online though. So we'll go ahead and call the meeting to order. It's 10:07 a.m. Thanks for joining us today. The first item of business is approval of the August 2023 minutes. Those were sent out previously. One note, because of the technical difficulties that we had last time, if you had joined online, we weren't able to record that in the moment, but if you need your name added to those minutes, please let Amber Schwips know and we will get that appropriately reflected. Otherwise, any changes to the minutes? If not, could I have a motion to approve?
So moved, Julia Kettner.
Thanks, Julia. And a second?
I'll second, Cora.
Zoe. All those in favor?
Aye.
Any opposed?
Aye.
Okay. Minutes are approved. I realize I skipped over introductions, so let's back up and do that as well. And we'll start with Kathy at the end and just go around this way, and then we'll jump to the people online. So,
okay, this is Kathy Leonard. I'm Director of Reimbursement and Actuarial Services for the Medicaid team.
Hi, good morning. My name is Darcy Tower, and I'm the Director of Provider Experience with Medicaid.
Hi, I'm Holly Cunningham Pickett, and I am the Director of Care Programs with OMPP.
Hi, I'm Maria Fennell. I'm the Chief Medical Officer for FSSA.
Good morning, Zoe Fran, CEO and President of the Indiana Council of Community Mental Health Centers.
Good morning, Fadi Kadura, State Senator, representing the north side of Indianapolis, Senate District 30.
Rita Fleming, State Representative, District 71.
Ed Clear, State Representative, District 72.
Good morning, Blair Viewig Hadley at the Insurance Institute of Indiana.
thank you. And then online, I'll just sort of call out names as I see them here. If you could just state your name and the entity you represent. Dick Road.
It's Dick Road with the Psychological Association.
Thank you. We'll skip that one. Elizabeth Wall.
Elizabeth Wall with the FSSA Indiana Pregnancy Promise Program.
Terry Cole.
Hi, Terry Cole with the Indiana Hospital Association.
Evan Reinhardt.
Evan Reinhardt with the Indiana Association for Home and Hospice Care.
Shane Springer,
Shane Springer with the Indiana Dental Association.
Deanna Ferguson,
Hi, Deanna Ferguson with the Indiana Optometric Association.
Elizabeth Eichhorn,
Hi, Elizabeth Eichhorn with the Indiana Healthcare Association.
Danielle Coulter,
Danielle Coulter with the Indiana Speech Language Hearing Association.
Julia Kettner,
Hi, this is Julia Kettner with the Indiana Primary Healthcare Association.
Michael Colby,
Michael Colby, member representative, governor appointee.
Representative Campbell, we can reflect that Representative Chris Campbell is on as well. Richard Nussel,
Richard Nussel with the Indiana Osteopathic Association.
thank you. And there's one other virtual attendee whose name is not listed. So if I didn't identify you, would you please state your name for the record? Okay, and I see Representative Karakoff also just joined, so we can reflect that he's present. Thank you. So the next sort of item of business we have is to approve the proposed dates for next year's meetings. So you can see those are set to take place February, May, August, and November of next year. We have historically met on a quarterly basis and plan to continue to do so next year. Just a couple items of note would be that they will all be in a hybrid fashion again like this. The next one would be in February, which would be in the afternoon. That's a change from when we normally meet. So just want to call that out. And then because of room scheduling, the final meeting of the year is set to occur at the State Library instead of here. Can I get a motion to approve the proposed dates for next year?
Those meetings are on the agenda, is that right?
That is correct.
Okay.
And they will also be reflected in the minutes.
Right. Well, I didn't get an agenda, so I guess if they'll be reflected in the minutes, I'll get the dates then. Thank you.
Sure. And Mr. Colby, we'll send you a copy of the agenda right now. Amber's working on that.
Thank you.
So do we have a motion to approve?
So moved.
A second?
But Terry Cole, the second.
Thanks, Terry. Any objections? Okay, those will be our dates for next year. We'll make sure that those are reflected in the minutes, and we'll also send out a separate email so that you can mark your calendars accordingly. Proceeding now to a rules update, we're joined by FSSA staff attorney Amanda DeRoss. Amanda, you want to go ahead and get started?
Sure. Thank you. Hi, everyone. Amanda DeRoss with OGC. I just have one rule to present today. So I'll just give you a brief summary of it and where it's at in the promulgation process. And then if you have questions about the promulgation process, I'm happy to answer those. So the one rule I have today, we refer to it as the CRMNF rule, which stands for Comprehensive Rehabilitative Management Needs Facility. It's LSA 23-727. And the proposed rule will amend 405 IAC 1-12-21 to increase the rate paid to, this is a mouthful, to any Medicaid enrolled large private intermediate care facility for individuals with intellectual disabilities that is licensed as a comprehensive rehabilitative management needs facility. And so the notice of public hearing for that rule was posted on November 1st. The public hearing will be held next Monday, December 4th. And then after the public hearing, OGC and OMPP will work together to respond to any public comments and make any necessary changes to the proposed rule. Does anybody have any questions about that rule?
I have a procedural question.
Sure.
So once you collect the feedback and you respond to public comments, Is there a role for the General Assembly, or is this more of internal FSSA rulemaking? And you have to submit documents to CMS to get approval. Is there a role for the General Assembly to play in that?
At this stage, there is not. I believe the General Assembly is notified at the start of the rulemaking process. Previously, I sent emails to the Legislative Council to notify under the new 1623 changes. I think you guys get notified by potentially SBA at the beginning of the process. But at this point, it doesn't go over to the General Assembly at all.
Great. Appreciate it. Thank you.
Yep. If no other questions, that's all I have for rules.
Thank you, Amanda. All right, moving then to sort of our substantive updates for today. We have 3 sort of topic areas that we'll be covering. And we're going to start with an update around the rate matrix, which Kathy Leonard will provide. I'm going to share these slides here.
Okay, thank you, Cora. Right. So whenever we have rate setting meetings, we always start with our FSSA strategic objectives for rate setting. So that's where we're going to start today as well. One of the key ones in, is it advancing? Okay, great. So some of the key areas, and perhaps you've heard about this before, the areas that we focus on, one is alignment. We want to make sure that the rates for similar services are equivalent across different agencies. Sustainability is obviously one of the most important things we look at rate setting. We want to make sure the rates are high enough to have a large provider network, but they also are within our Medicaid budget. Promoting person-centeredness and value-based purchasing. Again, we want to make sure services are available at the same type of level for individuals who have options, and we want to pay more for higher quality care. And then reducing disparities. And this is one that we've really been focusing on in terms of looking at how often rates are updated and whether or not members are disadvantaged or advantaged depending on the type of service they need. So for example, if nursing facility rates are evaluated quarterly, but home health are evaluated every 5 or 10 years, it may be more difficult for that member who needs home health care to access care. So we're wanting to reduce some of those disparities in those areas. So if we go to the next slide, one of the easiest ways and most predictable ways that we can set rates, and this is pretty small to see, but I'll walk you through it, is to set them to an index. And so some of our services have been set to an index, or they have a regularly scheduled update, and then that makes it much more predictable for the provider. So in the top block, we have there some examples. Pharmacy rates are set continuously. Nursing facility rates historically have been updated quarterly. Group homes have been updated every other year. And so we're trying to add more continuity to that. So you'll see at the bottom, there are a set of rates that we're showing that currently are going to be indexed to Medicare rates. And then that makes it much easier for folks to understand how we're reimbursing there. So historically, hospice has been indexed to Medicare, and some DME has been indexed to Medicare. Now we're going to have all of our DME indexed to Medicare, but also due to some recent legislation, emergency transportation is now tied to Medicare, and now physician and behavioral services are also going to be linked to Medicare. So we think that's going to make it much more predictable and easier for providers to understand. But Medicare is not always an option for rate setting. And so if we look at the next slide, Cora, please, that will show us when we talk about our rate matrix that we're looking at other services that haven't traditionally been re-rated frequently. And the first batch that we're showing on here are the ones where we just completed the rate setting, and that's for home health and for our waiver services. And as we're showing, we did rate setting for those, and then we're going to reevaluate those in 4 years. But we also are starting to now do our planning for the next set of rate setting that we're going to have for the next biennium. And so those will be some of the ones we're going to be shifting to looking at hospital rates and some of the rates for our behavioral health services. But we did want to give the group an update on the services that were included in this current budget bill. So if we go to slide 5, these are ones that we had introduced previously as we were typically calling them strategic investments that we needed to get caught up. We were paying at pre-COVID rates for our waiver services and home health, all of our home and community-based services. Our non-emergency medical transportation and dental services had not been updated in many years. And then our physician services needed to be repriced to meet the HIP rate equalization requirements. So those are the ones that we've been emphasizing and working on this year. And so we wanted to give an update on the last slide in terms of progress that we've made on those rates. So if you see in the top few rows, the waiver rates were submitted to CMS. Those are all effective now. We're paying those rates. The only thing that we still have pending on those are some retroactive adjustments for claims that were submitted prior to those rates being approved by CMS, and those are happening this month. Home health, because it didn't have to go to CMS for approval, the new rates were implemented for July. The home health providers have been getting those increased rates since that time. And then the additional ones, the non-emergency medical transportation, dental, and physician, those rates have all been submitted to CMS. They're targeted to be effective 1/1/24. So those will be implemented in January. And then finally, we have one waiver service for Department of Mental Health that CMS is currently reviewing, and that one will be effective retroactively back to 10/1. So, you know, we're pleased that we were able to get the approvals and that we have these higher reimbursements that are going to these providers. So this is, you know, where we are in terms of what was budgeted. Want to open it up for questions on these or any other rate setting activities that we've had. Yes,
Representative there.
Thank you. You mentioned dental. I don't know if there's any detail on that slide, but I certainly can't see it from here. Will you talk in detail, please, about dental rates, both adult and pediatric, remembering that we've had a lot of discussion and concern around dental rates since the last legislative session?
Yes. So in terms of dental rates, really, we had, I would say, 3 things that were happening at once. One was because of the federal regulations where we are required to reimburse across all of our managed care plans, we had to do what we call equalizing. And really the outcome of the equalizing is that the HIP rates, which are services primarily offered to adults, they came down a little bit and the rates went up for the other programs, for Hoosier Care Connect and Hoosier HealthWise. So that was one step. We had to make sure we equalized the rates. Then we also had a 10% increase that was a strategic investment. So we had that money to spend. But when we looked at just equalizing and adding 10%, part of what we found out is many of these rates had been set in the 90s and they were really way out of whack. And so we had to do a whole new rate realignment for the dental rates. So what we did is we had several series of meetings with dentists to talk about where the rates were now and where they needed to be going forward. What we ended up with was, in general, for more than 90% of the service types, those saw an increase. There were a couple of areas that saw a decrease in general in terms of the dental rates. But again, most of those cases, those decreases were supported by the dental community. So we tried to do it on a collaborative basis. As you can imagine, when you have a call with 30 people on it, there's going to be different points of view. And so you know, what we have to come up with is a compromise and something that's going to be reasonable across the board for all the rates. So in general, I would say that if you looked at things overall, pediatric rates increased more than the adult rates just because of that equalization. But many of the rates we set they're just the same rate, whether it's an adult or a child. So some of those are shared rates. So does that answer your question, or there's more specific detail that you're looking for?
Hey, Kathy.
Yes.
Sorry, I didn't know how to raise a hand on. I apologize for not being there. I'm getting ready to hop on a flight currently to head to a conference. Shane Springer with the Dental Association. A couple things I wanted to mention is, number one, I do appreciate, Kathy, the work that you and your team have done. I know the mandate that you guys were given rather. I appreciate the collaboration. I will say the new rates that have been proposed that we've seen, yes, our pediatric providers will see an increase. I have gotten overwhelming amount of emails and phone calls from our members who were already considering dropping out of the HIP program because rates haven't been raised in almost 10 years. And to see the state come in with this equalization process where most of those rates will be decreased is very troubling. And the feedback we've gotten is we are done. So my question to FSSA, and again, Kathy, thank you for all your work. I know the mandate you were given. You were always transparent. You were always open. My question to FSSA, do you guys have any concern about the future of provider participation in the HIP program for dental providers going forward?
Thanks for that question. Kathy, do you mind if I jump in here a little bit?
Right.
I'll speak a little bit from a policy standpoint on that. So Shane, thanks for that question. I think obviously access to dental services is something we are continuing to monitor, and we're not where we want to be overall. We, however, although it's not heartening, are not alone in this. Speaking with other state Medicaid directors, this is a phenomenon across the country. And I think what we've heard from the dentists we've spoken with is the rates obviously are a driver of participation and access to networks, but it's more than just that, right? It's provider abrasion points and making sure that we're reducing administrative burden and creating simplicity for providers. So while we are continuing to assess rates and we feel that the rate matrix will go a very long way in ensuring that we don't go so long between rate updates, and obviously dental will be on this sort of schedule along with other types of providers, and we'll have additional opportunities to look at it. I think we want to look at access holistically, which I just would really emphasize means more than looking just at rates. So obviously our provider relations team was very involved with our reimbursement team in this work. And that has been a critical piece to hear from dentists. What are the barriers or what are the challenges that make it so that you are choosing not to contract with or accept Medicaid patients? So again, more work to do. We recognize that, but we feel that the rates, the way that we've approached the rates is a step forward in that direction. Understand that it impacts each provider differently based on their particular payer mix of which types of Medicaid patients they're seeing. One item I did just want to clarify is that the equalization was a CMS, a federal requirement. So that was not a decision necessarily that FSSA said we want to equalize the HIP rates across other programs. That was a federal compliance requirement that we had.
Can we go to slide number 4? And I believe it covers ABA.
Well,
anything else? Sure, we'll get there in just a minute.
A
follow up on that?
But before we get to ABA, sticking with dental reimbursement rates for a second, Mr. Springer went where I was planning to go, which is to provider participation. And I appreciate the point about reducing abrasion, as you call it. But I'm hearing the same thing that Mr. Springer and his members are hearing regarding participation. I don't know realistically, certainly reducing abrasion is important, but I don't know that that is going to attract new participation or keep current participants in Medicaid. So do you have any expectation or projection regarding provider participation, say for the next 12 months, looking at what you're doing with so-called abrasion? Do you expect there will be fewer or more participating dentists this time next year?
I don't think we have an expectation or a particular target at this time, but happy to have some additional internal conversations on that and follow up with you. Certainly the monitoring of the trend is something that we plan on watching very closely.
Well, I appreciate that, and I'm happy to have internal conversations, but I think it's also important that the public be part of this conversation. You know, if a year from now we find that we have fewer participating dentists, then you know it's going to take time to reverse that. So I would hope that we would want to work to increase participation. So I'm a little concerned that you don't have a projection or a goal with respect to increasing participation over the next 12 months, particularly if you're making the assertion that reducing abrasion will retain or increase participation. So I think we should have a goal for maintaining and increasing participation by dentists over the next 12 months.
Appreciate that comment. Thank you. Well, we could definitely take that back and think about how we can do that. And partnering with the MCEs is a big part of that as well, in terms of their network participation. So appreciate that feedback, and we'll absolutely take it back to the team and think about a strategy there.
Thank you.
And Gord, just one other item to note: we have had some discussions with our provider relations team. You know, in doing any rebalancing, you have some rates that go down and some that go up, and that there's some opportunity for education around the rates that are going up, just to make sure that dentists are aware of the ones that are increasing, because there is a lot of focus on the ones that are in some of the ones that are being reduced. So I think that's another area that we're going to work on going forward as well.
Thanks, Kathy. There's a couple questions online too. So Representative Campbell, I saw your hand early on.
Thank you so much. Yeah, I'd really like to continue this conversation. There's a lot of different providers have really wanted to know. I know dentists were definitely one of them. So I think keeping us in the loop as far as does the rate changes increase the ability for us to increase providers throughout the state, and how much that is. And I mean, we really wanted to keep abreast of that. Also, I'm a little confused because I thought in the budget we were bringing everything up to 100%. So I'm a little confused about that. But specifically, I've had a question from mental health providers, and they want clarification as far as behavioral health practitioners and who will be and what their reimbursements will look like for LCSWs, LMHCs, LMFTs, and HSPPs specifically.
Thanks. Kathy, do you want to?
Yep. I guess in terms of a couple of things, and this is, I think, a question we've got quite a bit, is that in the budget session, there was a lot of focus on physician fee schedule, which had been proposed to be set about 83% of Medicare. And then there was a bill that was going to take it to 90%. And ultimately, it was set at 100% of Medicare. So I think because of that and that focus, that there might have been some expectation that 100% of Medicare applied to other service areas, but Medicare doesn't cover dental. So dental doesn't have a Medicare rate to send it to. We have to set it otherwise. And so there was not a provision to say, let's set the dental rates to HIP. I do know there was a dental bill that had gone through to significantly increase the rates, and that one did not pass. So I think it's very common that people are thinking, well, doesn't dental go up to 100% of Medicare, but there are not dental rates for Medicare. So I think that's...
Well, and my question was more about those mental health providers, if they count in that category of the physicians.
Yep. And I'm going to say we may have to take back your list of the specific providers, because I don't want to give you an incorrect answer here, but in terms of the rates that were set to Medicare, that's our general physician fee schedule. Our physician fee schedule was raised to Medicare as part of this HIP rate equalization. Now, there are certain services that were out of the scope of this, such as MRO services. Those are going to be evaluated for the next biennium, but generally anything that's paid off that fee schedule, it's going to be set at the Medicare rates. Now, depending on the type of provider, sometimes there are what we call cutbacks for different providers where we pay 75% of the rate or 80% of the rate, and those cutbacks will continue. So historically, if it's a provider that had a 20% cutback, they'll be getting a 20% cutback from the 100% Medicare rate. So I think we'll have to, if you could add in the chat or somewhere the specific providers that you're wanting it, we can get you that list and just confirm. But if they're paid according to the fee schedule, that's the way it will work with going forward.
And I'll just add that although it's called the physician fee schedule, there are other professionals who are paid under that fee schedule besides MD, DO level providers.
Correct.
So some of those that you've listed, Representative Campbell, to Kathy's point, very well may have been captured in that. We just, if you send the specific list or you drop it in the chat, perfect. Thank you. We will follow. Perfect. We will follow up on each of those individual.
Yeah.
Thank you.
Yeah, we're getting a lot of questions about this. So I think, us being able to provide clarity on this, is really going to be helpful.
Thank you.
Cora, thank you for the discussions you and I had on the ABA therapy rates. My question is, I know that in the state budget or with the state budget committee, when we met, we talked about the new rate that was discussed with the provider community. Has the plan been, or the amendment been submitted to CMS to finalize the details, or what is the timeline on that?
And Kathy, do you want to
yeah. So the ABA rates, because they just recently went to the state budget committee, they still have to have a 30-day public hearing. So our intent is to send it to CMS when that is done. Because of the tight timeline and wanting to get all these new rates and everything equalized, CMS has agreed to review a draft of what the state plan amendment would be. So we are providing that information to CMS so that they can be reviewing it in advance of the end of that public comment period.
With the public comments, does the public comment or will public comments influence in any shape, way, or form FSSA's decision on that rate? And any, whether, I've heard since the state budget committee met, feedback and suggestions, including since some of the providers will get a little bit more than what they currently charge, some will get a little bit less based on the presentation that we went over. Some have suggested why not to keep that negotiation, that space open between the providers and FSSA to set the new rate as the floor rather than the hard-coded rate, meaning you can still move forward with the rate that you proposed, but by setting it as the floor in your submission to CMS, it will still allow for dialogue between the agency and the providers in case we start seeing some folks exiting the market and FSSA needed to respond administratively to some of that. I think when we met, we talked about the management overhead versus the hourly workers and what would be appropriate and all that. What are your thoughts about that suggestion to set that as the floor rather than the rate, which doesn't change anything, meaning FSSA can still move forward with that rate, but it also provides flexibility to continue the dialogue between the providers and the agency?
Yep. So, the way the rates are being filed is they're being filed as a minimum fee schedule. And because the majority of children are covered under managed care, if an MCE is finding that they're having challenges with access, there would be an opportunity for them to say, we're going to raise our fee schedule in order to ensure access. So I think there are, some flexibilities there, but really our intent is we are going to, we are submitting these rates. We're not looking at, based on that comment, stopping them or delaying that or replacing them. But obviously access is a major concern, and we've been mapping out, where the providers are and comparing high cost and low cost. And we feel like there is good coverage where if some of the higher cost providers decide to exit the market, there should be a lower or medium cost provider in that area. But if we find out that's not the case, then I think we will have to, to look at adjusting things accordingly.
So the language will use the term minimum rate, correct? If I heard you correctly.
It's a minimum fee schedule, similar to what we're doing on really all these rates that we're rolling out.
So hypothetically, and from an administrative perspective, if you need to increase the rate for a certain region, for a certain community of providers, because they might be exiting the market, that will still be within FSSA's jurisdiction to have that administrative negotiation with these providers to make adjustments to that rate?
No, typically, what we're setting is the minimum fee schedule, and that's going to be set for fee for service. I'm saying that the MCEs have a little bit more flexibility to make some changes on the fly on those, but I think we will collectively want to look at how the access is turning out to decide if there's anything we think we need to do.
I appreciate you looking to continuously look at this. As I mentioned in the State Budget Committee meeting, as a former FSSA employee myself, I used to respond to legislative inquiries from legislators. Now I'm on the other side of the table. So my point is that I know that once the General Assembly moves forward with appropriating the dollars, you present to the State Budget Committee, they give their consent. We're not really approving your appropriation because it was approved in via the General Assembly. So we as legislators representing our communities really have not much influence once you submit the documents to CMS, and then we start hearing back from our constituents and from our providers. So I urge you to continue to be extremely diligent in looking at access, looking at providers and how they are impacted, and most importantly, those who are receiving the services. And if I may switch on one more question on the rates, if that's okay. And the home health, you mentioned home health earlier. I'm receiving a lot of positive feedback from my community. And I was very happy with many of my Democratic and Republican colleagues to pass a law last session with the help of FSSA to continue to work on home health, the strategic plan for the state and all of that. One feedback that I received, some families who work evening shifts, mom works in the morning, dad works in the evening, sometimes both work in the evening. Home health agencies are finding difficulty attracting pediatric nurses and others during after hours and on weekends because they prefer just to work 9 to 5, go home. And so some of these families are making very difficult decisions to say, I'm going to give up on my evening shift, forego those dollars because I have to stay home and take care of my, child who have severe health conditions. What are your thoughts on that? Administratively trying to incentivize some additional maybe rate increase for after hours and weekends to be sure that we're still attracting workers or home health workers in the evenings to support these families.
I think we have heard the concern certainly around the pediatric. I'm looking at Dr. Fennell because she's also been involved in some of these conversations as well. So I think we're continuing to look at that as well. And speaking with the provider agencies around what are their needs in terms of making sure that they're incentivizing that in order to have the care that is available at the time that a family needs it. So certainly appreciate that comment, Senator. And I think it's certainly on our radar.
I appreciate you. I'll conclude by saying I met with these families. They showed up at the governor's office when he signed the law. For those of you who have never met these families, I know when I worked at FSSA, many times we were distanced from working with patients because we are on the policy side, but when you meet with these families, these children, many of them are non-mobile. They're paralyzed from the neck below. Many of them are non-verbal. Many of them have to receive their feeding via tubes. And it's unbelievably the amount of love that these parents and sacrifice and courage to raise these children and give them the best opportunities is unbelievable. So I think I've learned in my own district that there was a family where one of the parents had to give up their job because of that. Outside of my district, I've heard of family, a mom completely gave up on her career because she decided to stay home and take care of her child. So I really appreciate your attention to this. It's extremely important for our kids. Thank you.
We understand and agree. Thank you very much for your comments. Maybe one more question on this topic, because we've got a couple more to get to. Oh, actually two, because I saw Zoe's hands up earlier. So Representative Karakoff and then Zoe.
Thank you. My question regards home health care. I've had a provider reach out to me and ask why they've been asked to accept the rate that has been paid prior to the adjustment being made. Like sign off, like we're going to accept what you've paid. We don't have any expectation of a reimbursement. And that's coming from a AAA.
So I think that's a little surprising, given that the home health rates were implemented prior to 7/1. So there shouldn't be an instance where they are being asked to receive an old rate because the rates were implemented prior to the 7/1 date. It could be that they're maybe thinking about a waiver service and thinking of that as home health. And for those, we are automatically, if they had submitted the claim with a higher rate, our system is going back and paying those at the higher rate. So we wouldn't have asked them to accept the lower amount. If they had billed us using the lower amount, they have the option to rebill us at the higher amount. So that definitely would not be direction that would be coming from the state.
Representative Karakoff, if there's a specific constituent you'd like us to connect with, we'd be happy to follow up and sort of that doesn't sound I don't want to say it doesn't sound accurate. It doesn't sound like what should have occurred. So if you send it to Gus and myself, we'll take a look quickly.
Would the AAAs have anything to do with home health care reimbursements? Or is that an entirely different, that's waiver based? They got to get their waiver to get the home health care, correct?
So, I mean, they work on determining the services, but the AAA shouldn't have any voice in the reimbursement.
Okay, thank you. I'll get with Gus and give him the particulars.
Thank you very much. Okay, Zoe.
Thank you. And thank you to all of you for your work on this. A couple questions that I have in regard to mental health is HCBS. I know all HCBS funding is slated for an increase. Mental health does have HCBS mental health component. And so I just didn't understand why the mental health waiver under HCBS is not part of the others. That was one question that I had, as well as could you provide clarity on the DMHA waivers that are being evaluated?
So we are going to be having a meeting to look at our strategy for the next biennium for all of the mental health type of waivers. So it's a little early for us to comment on them, but they are slated to be evaluated for the next biennium, right? So a broader look at where do we need to refresh our rates. We have MRO rates, which have been set many years ago. You know, we're looking at new models for behavioral health. And so that'll be part of our planning going forward, but we're a little too early in that process to really
So the HCBS mental health will be part of that discussion is what I'm hearing you say. Okay, yes. Wonderful. And then my understanding, just getting back to Representative Campbell's question regarding the physician rate, the 4 masters that she listed, the LCSWs, the LMHCs, that licensed addictions counselors and the licensed marriage family therapists, that is based off of percentage of physician rate. So it does remain at that 100% of physician rate was my understanding on that.
Okay, thanks. Thank you for that. We'll
get clarification on that.
We'll confirm that. That was kind of my inkling, but great to hear that that's your understanding as well. And we'll still follow up with that final confirmation on that. Okay, great. Thank you very much. There was a specific question I think Mr. Colby asked in the chat what the ABA rates are. We can reflect that in the minutes perhaps, because there's more than just one. There's one particular rate that was the primary utilized service, but for the purposes of being all inclusive, we can spell
we
that.
could send out a table because we also have different rates depending on the practitioner, so we can give a full summary.
Thank you. Thanks, Kathy. Appreciate that update. All right, turning now to maternal child health. Again, we're joined by Dr. Fennell, and Elizabeth Wall is online. There we go. And we'll turn it over to you. Thank you.
Thank you so much. Can you hear me okay? Hey, everybody. Happy to be here. I'm Maria Fennell, Chief Medical Officer for FSSA. I am a pediatrician by training and are still active clinically each week. So I'm going to give the update on maternal health from an FSSA, all over FSSA standpoint, Medicaid and Medicaid providers, of course, and how they're affected. But some things have been done in the Medicaid program. A few things have been done within other divisions of FSSA. I'm going to talk a little bit about coverage extensions and changes first. Then I'm going to talk about some initiatives we have taken in the as a result of special session and the funding that came after that. And lastly, we'll do an update on the Pregnancy Promise Program, which is our care coordination program for pregnant women with substance use disorder, or really specifically opioid use disorder. So next slide, please. Oh, great. No, stay there. So the first thing, this is a little bit of a look back over the last year plus, and a reminder. I think it's good for everybody to be oriented to. First thing, as far as coverage that was happening in April 1 of 2022 is what the postpartum coverage period for Medicaid, traditional Medicaid, Healthy Indiana, and Hoosier Healthwise was extended from 60 days postpartum to 1 year. A big change, really important change, given that pregnancy-associated deaths are really measured over the 1 year after delivery. So important for women to have coverage over that period. The next thing on the slide addresses prenatal tests and screening coverage. So effective December 1 last year, Medicaid expanded the coverage really for prenatal screening without prior authorization for routine screening of women. There are two parts to this. One was to assess sort of testing of the fetus, and the other part of it was to make sure that certain inherited conditions that mothers could pass on to infants were sort of known, and that was of course mothers only need that type of screening once. They don't need it for each subsequent pregnancy, but that was put into place last year as well, and that was to align and make it more comparable to commercial insurance and the standards we practice there. Next slide, please. This is not necessarily an extension of coverage, but it is access, I think it mostly addresses. So LARC has certainly been covered by the Medicaid program, so long-acting reversible contraception. But what we did, or the agency did in November of last year, was to carve the payment of LARC out for FQHCs and rural health clinics, so that providers could be separately reimbursed for long-acting reversible contraception. This was already the policy when it came to inpatient stays. So if a mother delivered, the payment was one for sort of the delivery, and separately the device could be reimbursed, but that was not the case for FQHCs and rural health clinics. So this was done last year in an effort to really make sure that the payment was not in any way hindering access to LARC for women when they came into these settings. And the next coverage extension that was done was the addition of milk banks as a standalone enrolled IHCP provider. Donor breast milk is really important for some babies that are born early, prematurely, and who are not able to get, for one reason or another, not able to get breast milk from their mother. There are a small percentage of those children that really benefit health-wise to get donor breast milk. Donor breast milk has been covered in the inpatient setting before under the DRG that has been accessed, but there's a very small group of children that need to go home on donor breast milk for a period of time in their early infancy. So this, and that wasn't possible under the Medicaid program before because they were not a enrolled provider. So now that has been put into place, and as of this year, that access is possible. Next slide, please. So those 4 things were more about coverage. This is about initiatives that was taken to increase access to some degree, but also increase quality and making sure that increase the quality of our program. I think we should call this particular initiative. So in the past, there has been something that's called the Be Happy line. The Be Happy line was really put into place for pediatric providers around Indiana to be able to call in and get a pediatric psychiatry consultation on the phone. And the reason that's important is that it's very important that patients are able to be kept as much as possible with their primary care providers and not having to drive long and far distances for specialty care unless it's absolutely needed. We heard loud and clear that was a very welcome change in the pediatric space, but there was a void in the adult space for providers taking care of members with substance use disorder or adults with mental health diagnosis, but very much so also in the perinatal space. It's even more, it's a difficult, when somebody's pregnant and need psychiatry medications, that's a balance that many providers are not necessarily comfortable with unless they have specialty expertise. So in this case, this line was put up, this program really is under the Division of Mental Health and Addiction. It's IU are administrating it, and it gives provider an opportunity to call in while they're caring for a patient and get a psychiatry specialist in perinatal care to respond within 30 minutes, if that's the minimum or the time we have set that's acceptable in the contract, or if the provider wants a call back later, that's of course possible as well. But to really get that subspecialty expertise and be able to keep their member in their practice. They will also then receive a brief written documentation of the recommendation as well. Next slide. In addition to this, there's been grant opportunities provided, and the funding that has been used came through after the special session. And one of those is specifically targeting long-acting reversible contraception. This was a request for funding that was released, and with respondees, and the one grant awardee was Path for You, that is also an IU program. And this was a pilot program that was actually upstanding already in Indiana since 2020, but this 1.15 million grant award made it possible for this program to expand to additional sites around Indiana. So they expect to have 11 additional clinic site partners and be present in 53 counties for actually direct access to LARC, and with the emphasis on being able to get LARC the day you want it and not have to come back for an additional second visit for long-acting reversible contraception if that's what the woman desires. Next slide, please. The next funding that was distributed was the request for service to invest in already existing maternal child health programs. and that were meeting either one of, there was 8 eligible spending categories, and those included supporting the health of pregnant women, postpartum mothers and infants, or pregnancy planning, including, again, addressing LARC. That was one of the criteria. And then supporting the needs of families with children who are really young, less than 4 years. So this was the Hoosier Family Fund, first fund. There was 32 applications that were awarded. A total of $4.5 million were awarded in 36 counties around Indiana. And you can see there on the map how they were distributed. So some of the example, there were many different types of initiatives or existing program funded, but some were doula services, expanding already existing home visiting programs so they can serve a bigger population, vitamin K awareness, which is really important for newborn infants to get, and so forth and so on. Next slide, please. This slide represents really initiatives underway that are in planning stages. To the left is doula services, and to the right are planning for maternal home visiting. I'm going to start talking a little bit about the doula services. As you may know, there was a doula reimbursement advisory board that came through with the legislation that's appointed by our legislators, and I believe are still awaiting some appointments. But what FSSA have sort of taking charge of doing in this space is to really look at how could a doula service look to be a Medicaid reimbursable benefit. Currently, and some of you may know this, FSSA has a community health worker benefit in place since around 2018. Doulas around the state of Indiana has very loud and clear sort of expressed that they are not necessarily community health worker, but nor does the model we have set up as far as reimbursement work for their workforce, because they tend to spend more time servicing and helping, supporting mothers around the delivery, right before delivery, during delivery, and after delivery. And certainly the community health worker benefit is not set up that way. So the FSSA is looking at how would a doula benefit actually look in Indiana. And what has been done to date is that there has been a quite intense stakeholder engagement going on with, I believe there was 60 or so plus doulas or groups representing doulas present over a series of stakeholder engagement meetings, and to learn both about sort of how doulas work, how the benefit would have to look in order for actually be working for doulas, how doulas could imagine how they would enroll and sort of be able to use the Medicaid benefit. And of course, also input in regards to sort of how reimbursement may need to look. So that stakeholder engagement has to happen. There is a draft plan that's coming together that we are yet to sort of discuss and receive. But the hope is that when there is the doula reimbursement advisory board is in place, that there's some recommendations that can be put in front of them based on the stakeholder work that has happened. So that's doulas. And then separately from that, maternal home visiting is already existing in Indiana. These are the referral program, My Healthy Baby, is administrated under Department of Health, but the maternal home visiting programs are, the providers, so to speak, are for the most part they are funded either by grants or by other state funding. Some states have moved to looking how would it look if some of these programs are able to actually bill Medicaid for their services, and could that offset some of the cost, and could it free up resources for other programs? So that's the planning that work stream is doing. They have also engaged with stakeholders, and they have got quite a lot of input and as far as how these programs look at Medicaid and their ability to be able to be reimbursed by Medicaid. So this is also under planning right now, and something that we need to take the review the plan and figure out the next steps if we would agree make that change. But the goal would be to increase capacity of maternal home visiting in the state of Indiana. Next slide, please. Lastly, I want to talk a little bit about the updates from our Pregnancy Promise program. This is the grant that FSSA has from CMS. It's an innovation center grant. We're currently in year 4 out of 5. This grant is about pregnant women with opioid use disorder and care coordination for those women to improve outcomes. While FSSA is administrating the grant, the work is really carried out by our Medicaid managed health plans. So the care coordinators that are connecting with the women are in the managed care entity. So next slide, please. Some of you have heard this, but to be eligible, participants must meet the criteria of either being pregnant or being in the first 3 months after the pregnancy. They need to be identified as having indeed current or previous opioid use, and then they need to have Medicaid coverage. Next slide, please. So our team that are working on this have sort of provided the following updates today, and it's that currently 675 enrollees have been served to date. 475 infants have been born to date, and in the program has actually enrolled Hoosier women from 86 counties to date. The enrollment trends are that mostly 89 participants have been identified as white and non-Hispanic, and this is a number we have looked into because making sure that the program is available to everybody in Indiana, regardless of ethnicity and race and so forth. There has been some, we know that opioid use disorder is more often diagnosed among white women, but we have certainly also recognized that we have a higher acceptance rate among white participants versus other minorities. So that's something the program is looking into. 70% of participants are between the ages of 25 and 35. 95% of these women have not only the opioid use disorder, but also other mental health conditions. Very, very common. And the majority of the participants are enrolling during pregnancy, but certainly 35% also in those 3 months postpartum. Next slide, please. The exciting news here is that this program has really had an incredible retention percentage. So 94% of the mothers that participate are staying in the program. 94% of the women in the program have no documented or reported setbacks or return to use during the time in the program. That is a very, very high number if you compare to literature. So that's an amazing outcome. 92% of infants discharge home with their mother following birth. So they are going home with their birth mother and not in foster care or something along those lines. 82 to 85% of infants are born with a healthy birth weight. 72% are discharged after a short observation stay in the hospital, 0 to 5 days, which is something we want to see being really high. We know that infants having to stay in the hospital treated for neonatal abstinence syndrome because of their mother's opioid use is certainly a separation, but it's also something that drives cost. 50 to 55% of these infants receive breast milk from their mothers, and 30% are receiving a diagnosis of NAS, but still in a very, very high risk population for that. So we are excited about these outcomes to date. Elizabeth Wall, who's our program director for this program, is online if there's specific questions about this program. I think that was my last slide. Thank you so much, and I'm happy to take questions.
Very much. We have one quick question from Senator Charbonneau online that I think we'll be able to answer very briefly. He asks, is postpartum coverage for a year now in effect?
Yes, that is indeed in effect. It is important that our the Medicaid member is recognized as being pregnant, so it's important that pregnant mothers notify DFR that they are pregnant so that they really get that 12-month postpartum coverage. Our managed care entities are also assisting us with that data, but yes, it's in effect already. Yes.
Thank you.
Go ahead.
Okay. I was referring to you. I had a question. I mean, the 94% no documented reported setbacks or return to use is, I mean, it's like incredible. Are we documenting information as to why that is from these mothers?
Yeah,
I mean, it would be anecdotally, but
we know anecdotally as far as and we are looking right now and trying to figure out. It's hard, right? It's a cell. You volunteer into the program. So it's obviously probably some selection into the program versus not being in the program. We are trying right now to do a comparison with similar women not being in the program and look at outcome and so forth, because that would be important. But yes, I agree with you. We are thrilled about this number.
What is happening in the program? I guess I would want to know details. Is there anything that we can look to specifically?
I would say one thing, and Elizabeth is able to speak to this in greater detail than I am, so we'll see if she's able to come off and comment as well. I would say that these care coordinators are working incredibly hard to look at all the needs for these women, which are sometimes, it's not just about the medical needs and making sure you get your medication, but sort of the social needs, sometimes the housing needs, being safe from partners and things like that. They are really working incredibly hard to meet all those needs, making sure that there is support, wholesome support for the woman during this pregnancy.
Well, somebody out there needs to look specifically, because we should have great data from this and see if there's anything that's transferable to other programs. Because what it sounds like is the connectivity, which we've been saying.
Yes,
people, it is really important to have people feel connected.
And something that we have learned that's eye-opening, it was really eye-opening for me, is that it takes on average 7 to 8 attempts to reach women before they say yes. And we typically don't do that in programs, right? Like, that's too many asks. We have given up before that. In this program, they don't give up. They keep asking. And so it takes that much, but when they are able to connect, clearly the outcomes are quite remarkable. So
thank you.
Yeah.
And is that 94% like over a year period, or what is that since the program started?
Elizabeth, are you able to come off mute and maybe respond to that so I don't get that wrong?
Elizabeth, you're off mute, so if you're speaking, we can't hear you. Or if you want to drop it in the chat, I'm happy to read a response.
Yeah.
And I can follow up.
Otherwise, we can take it back. I just don't want to. I don't want to respond incorrectly, so we'll take it back.
Because in addition to 7 to 8 times of getting them on board, it's also usually 7 to 8 times of needing to go back into treatment. And so that 94 is really sticking out to me. So whatever that success is, I definitely would love to share that as a evidence-based practice with providers. So good work.
Thank you.
Representative Fleming, and then I would be Representative Kerr, and I'll stand online as well.
Thank you very much. And thank you very much for the update. I think as a pediatrician, you get the fallout. You see the consequences. I'm sure you see the consequences of unintended pregnancy. So I'm glad that we are finally paying attention to preventative methods. We're not doing nearly enough, though. And we don't reimburse well enough. The providers in my area tell me that they would be fine with putting an implant in during the postpartum period while the patient is still in the hospital, but it's not worth it. It takes 15 to 20 minutes away from the office, and they would like to do it. They say it's not unbundled. A nurse practitioner could do it. A midwife could do it. A physician could do it. There needs to be more incentive for people to provide it. We know that unintended pregnancies are extremely costly. The consequence of prematurity, congenital anomalies, STDs, congenital syphilis is on the rise, and then all the fallout. These kids are more likely to use drugs themselves. You know, it just goes on and on. So I applaud the effort that is being made, but we need it. We need a much stronger effort. We need to go where people are too, because when I encountered a patient with no prenatal care in the hospital who delivered, the chance that she's going to see a provider is very, very small. So for those folks, again, we need to be where they are. Again, in the postpartum units, in the emergency rooms, in the drug treatment centers, mobile units, to go where these women are who, I promise you, want these devices. It's easy to put in, it's effective, it's 3 years of contraception. The 1.5 million is great. We need 10 times that. Thank you.
I'm sorry. Well, Elizabeth responded. I'll read this briefly. So she was having trouble coming off of mute, and she shared that we're required to report relapse, return to use to CMS. The high rate of sustained recovery has a lot to do with the relationship between participant and nurse case managers, as you alluded to, Dr. Fennell. We offer a lot of education about risk of relapse in postpartum period and connect 1 to 3 days following delivery to be sure there is continuity of opioid use disorder treatment and mental health services in that postpartum period. Thanks for sharing that, Elizabeth. Representative Karakov.
Thank you. Could you tell me, we've got a lot of percentages, what's the raw numbers of folks in the program?
Yeah, so if you go back one slide there. Cora. So it should be recognized that it's right now the number is between, so 675 enrollees to date. That doesn't mean that the 675 are not currently in the program. You are in the program for 1 year postpartum. So some participants have already completed that program. The number right now is around, I believe it's 380 or so active.
Thank you.
Yeah. Indiana has the highest enrollment rate across all CMS awardee states. That is correct. Elizabeth is commenting on that in the chat. We have the highest number of enrollees for this pilot program. So, but in addition to that, I would also say we have taken a different approach, making it statewide and leveraging our managed care entities because they are already providing care coordination for Medicaid. So that approach is different than many other states have done in this regard.
Would that be the reason why we have good participation?
Yes, I believe that's part of it. Yes, we're like sort of adding on to a program we're already running and making it enhanced. Correct.
Okay. If you no other questions, thank you so much for your presentation, Dr. Fennell and Elizabeth, for your work on the Pregnancy Promise program. We're really proud of that particular program and appreciate sort of the all of FSSA approach to this work. And we're very lucky to have Dr. Fennell and her expertise as a clinician in the chief medical officer role for the agency. Transitioning now, and I'm going to flip my screen share. So bear with me one moment. We're going to transition now. We have a number of individuals here, Holly, as well as Darcy from our OMPP team are going to provide an update around the Pathways program. This, I'll just do a quick time check here because I know we've We'll also have a brief comment period at the end of this. So I want to start by saying this will not be the last time we talk at MAC about the Pathways program before the July 1 launch. We wanted to sort of provide you with an update of where we are status-wise, but certainly more to come. So with that, I will turn it over to them as I pull the slides up.
So, hello, I'm Holly Cunningham Pickett, and I'm the Director of Care Programs at OMPP. And I have the pleasure of working very closely with the managed care entities to launch Indiana Pathways for Aging. We will be launching this program effective July 1st, 2024. And this program will cover Hoosiers that are age 60 and over who have Medicaid, and they may also have Medicare benefits. I would say majority, about 80, a little over 80% of the projected membership for Pathways will be what we call duals. So they'll have Medicaid and Medicare. And one of the main, I would say, talking points around Pathways is that ability that we will have in the future then to help coordinate that Medicare, Medicaid benefits, whereas today we don't have that kind of coordination, and it's very fragmented and often operates in silos. So this first slide here, I just want to point out that this is the Pathways logo. If you haven't seen it yet, these are the Pathways colors. These will be what the MCEs and FSSA OMPP are using to promote and market. And Darcy's going to talk about that a little bit here after I'm done with this program update. If you can go to the next slide. I wanted to just step back real quick and make sure that everybody understood the Indiana Pathways for Aging program. As I said, we're going to launch July 1, 2024. The target population is Hoosiers that are 60 and over. They have to be on Medicaid. That is the one thing that everyone must have, but they may also have Medicare. They may be living in a nursing facility or receiving hospice services, or they could be receiving home and community-based services. The three, I would say, overarching quality goals are to promote and increase all of our person-centered services and supports, ensure smooth transitions. We have a population that is older and tend to be in the hospital or need rehab. And so this program hopefully will provide the attention and support individuals need to remain in a setting that they prefer. And then access to services. We're going to be using our MCE friends to really help us make sure we have an adequate network and the individuals have access to that network of providers. Next slide. So Pathways is a managed long-term services and support program, and we procured bids for the program, and we awarded Anthem, Humana, and United Healthcare to help us support the program. They will be hopefully our LTSS experts that will be helping to make sure that we are delivering the right services in the right setting at the right time. Each MCE will offer the same Medicaid health coverage. They'll offer the care coordination services, and then they each will have what we call enhanced benefits, but they're really value add that, that maybe additional transportation to community outings that isn't a Medicaid covered service. And our members will begin to be able to select those MCEs starting February 2024. Next slide. So to get ready for implementation and to make sure our MCE partners are all on the same page with us, we do what's called a readiness review process. This readiness review process is something that we are really working hand in hand with our MCE partners on. I would say that I feel like we are really in a collaborative and partnership kind of frame of mind where it's not us and them, it's all of us trying to make sure that we are implementing a program that has value to Hoosiers that are 60 and over. So what we're going to be doing is we have this robust process where we're going to validate the ability of our contracted MCEs to be able to go live. We know that they're ready to go live. And we do that through like a desk review where they have to submit policies and procedures, but we also do it by going on site. We have them do demonstrations in their systems. After we go live, it's not necessarily called readiness, but we're going to be doing quality audits where we listen to phone calls with members to make sure that the messages are on point. We'll be sitting with care coordinators and listening to them do assessments, or going out in the community with them while they do assessments. So this is a very collaborative and very strong partnership where we're kind of all working together to make sure that we are meeting the needs that we've set out to meet. I think we can go to the next slide. So the next slide is really just kind of a general timeline of implementation. At this point, we are really at the managed care entity readiness section, and then the systems testing. I mean, we're really kind of, up to our eyeballs right now in those activities, and making sure that, we are going to be ready to go July 1. Now, readiness will end around April of next year, so that we have a couple of months if we need to reevaluate or actually have maybe some redemonstrations done by the managed care entities. We'll have time to do that before the go live. And then obviously our ultimate go live date is July 1, 2024. And then Darcy's going to talk about how we're going to communicate all of this to the community and to members, if you want to go to the next slide. But this is just a go live, another very general timeline, but this is what the member will be experiencing through this go live process. So starting in February, we will be sending out the initial enrollment letters explaining what is going on. They will be able to call the enrollment broker and select a health plan starting in February. They can ask questions of the enrollment broker as well. We are doing a lot of webinars and trainings, and we're going to really be ramping those up starting at the beginning of next year, so that we can make sure that our providers communities are ready, that our community partners are ready, and that the members understand what's happening. And so you can see here just what we've projected as like the general timeline for our member experience. I'm not going to go through each one, but I'm going to get ready to pass this over to Darcy. But is there any questions before I do that? Representative Clear.
Thank you. The 3 MCEs, there were 4.
There were 4. And
Molina disappeared. So will you please talk about that? It sounds like there were some process issues, and I'm concerned about the process that led to both Molina being selected and then dropped. And is there going to be any consideration of selecting a 4th? I mean, obviously there was a thought that 4 was the right number, and there were other MCEs that submitted, correct? So why aren't we going out to get a 4th as a replacement for Molina?
Thanks for that question. I'll jump in here, and then Holly's welcome to add or clarify anything needed. So yes, initially, and Holly, I apologize if you already said this, but we have not executed contracts with any of the MCEs. That takes place at the end of the readiness period. So we had put out the awards for the 4, as you mentioned, Representative Clear, and Molina was included in that. One of the requirements that we laid out in the scope of work, Holly mentioned about the real opportunity we have to improve alignment for our dually eligible population, those individuals who are eligible and enrolled in both Medicare and Medicaid. One piece of one sort of strategy that we think is going to be really helpful in that alignment is leveraging the use of what is called a dual special needs plan, or DSNP. So each MCE, before even bidding the scope of work, when it was first developed through sort of a stakeholder feedback loop, we included a requirement that each MCE had to have an active DSNP. Molina was unable to secure a DSNP contract, which is a CMS approval for the state of Indiana. And so they were unable to meet the contractual requirements under the scope of work, which mandated that they have an Indiana active DSNP at the time of go live. So that was really the reason why we opted to not proceed with the readiness activities and eventual execution of a contract in that regard, because of the requirement to have a DSNP, which they were not able to meet. As to the question around including additional MCEs, other MCEs did bid on the Pathways program. Because of where we are in the readiness, that would be a very large undertaking and carry a substantial amount of risk, honestly, to bring one along at this stage in the game when all of the other readiness activity that has already occurred. We feel confident that having the 3 MCEs, we will be able to provide appropriate member choice and maintain really a robust and high quality program with those 3 MCEs, Anthem, United, and Humana. Holly, anything you would add?
And I would say that between Anthem, United, and Humana, they have about 90% of the current DSNP population that's in our state. And so bringing in a 4th one at this time, I think would not be productive for us or the 4th MCE to try to get them, brought up to speed by July 1.
And I'll just add one other piece, which is we did not go into the selection process saying we were definitely selecting 4. That's just what occurred as the result of the procurement activity. So that's another reason why we feel comfortable with the 3, staying at the number 3.
Were any of the MCEs that responded but were not selected, or did any of the MCEs that responded but were not selected already meet the DSNP requirement?
I'm going to need to double check that for sure. I can't recall off the top of my head who else are DSNPs in the state.
We're happy to follow up.
Yeah.
I'm hesitating a little bit because of the confidential nature of the procurement process, and I just don't want to accidentally say something that is not within the ability to say. So I'd like to just circle up, and then happy to share what I am able to share with you, Representative Clear.
That's fine. I'm among other concerns concerned about how Molina was selected without meeting the DSNP requirement. It sounds like they committed to meeting it at a future date, but didn't have the ability to satisfy that commitment.
And I can add a little bit to that context to that. So we submit DSNP or insurance companies submit their DSNP request in February-ish, and they usually get notified somewhere around between April and June. And so February of 2023, they would have submitted, and there was no reason for us to think otherwise that they would not be approved at that time. So it was kind of a, well, and then let me also back up that we don't require them as part of readiness. They had to have it in place by July 1 of 2023. So that would have given them plenty of time to meet that requirement.
Representative Fleming? And then I see Representative Karakoff's hand. Sorry.
Thank you. Excuse me. Thank you. Humana has limited their offerings now of insurance. They don't offer the employer coverage anymore for workers. So given their narrow portfolio, which I'm sure is based on profits, they are still eligible. I have a couple questions. So they are still eligible to participate as an MCE.
They are because they are currently operating a DSNP in the state for Medicare, and they were approved to continue when they submitted their contract to CMS earlier this year.
Okay. Do these 3 entities, United, Humana, and
Anthem?
Yeah, Anthem. Do they own nursing homes?
No.
None of them own. They don't have a subsidiary that owns nursing homes.
We'd have to, I think, ask them specifically, but not to my knowledge.
Okay. The most important metric, at least as far as I'm concerned, is can individuals age at home? And I'd really like to see that tracked, because if there is an profit to be made for persons to not be at home, then unfortunately I could see that happening.
Yes. So Dr. Resniak, one of his main points that he's really been pushing and making sure that this is in our, in the front of our brains, is that we really want to try to, we don't want to eliminate, if someone wants to be in a nursing facility, that again, that goes around that person-centered process. But we want to make sure that people who want to age in place or want to age in the community or in their home or with their adult children have that opportunity, and that we see a reduction in future nursing home, long-term care nursing home admissions, and see an increase in home and community-based services and support. So that's literally what we're aiming for and what we would like to do. I mean, that would be what our happy outcome would be.
Okay, thank you.
Representative Kirchhoff and then Senator Kadora.
Thank you. So this is a issue I've kind of paid attention to because there's a lot of angst about how this is going to roll out. I have a couple of questions. During February and March, the member's going to get a plan selection notice from an enrollment broker. How many plan selection notices are going out? And the enrollment broker, are those employees of the 3 MCEs, or are they somebody else? How many are going out, and who does the plan, the enrollment broker work for?
So the enrollment broker is Maximus. They're the current enrollment broker as of today. And so
it's a third-party vendor then.
Yep, they're a vendor for the state to do the enrollment. The notices, we will send out one notice in February, and then Maximus, as the enrollment broker, will be doing calls after that notice goes out. So they're going to attempt 3 calls to then verbally explain what's happening. About 60 days then before go live, so around April, another notice will go out, and then the MCEs will also start sending out notices as well. So what's
the estimated total number that go out? That's what I'm looking for. Like 5,000, 50,000, 200,000. How many notices go out right at jump in February in preparation for the July 1st launch?
We anticipate about 130,000 individuals that will be participating in Pathways. So about 130,000 notices will go out in February.
They're all people that are currently being covered.
I'm sorry, we didn't quite understand that. Currently,
these are people that are in a healthcare facility right now, or living at home and getting home health-based care, or assisted living. These are people in the system right now.
Yeah, correct.
What happened to the idea that we were going to ramp this up slowly, and as new people entered the system, we were going to sign them up and present that opportunity, so we didn't have the Southeast trans like we're flipping a switch and everybody's shifting over? What happened to that idea? Because this is very different than what I had understood was going to be the launch.
I think at various times, Representative Kirchhoff, there have been proposals around pilot approaches or restricting to a certain geographic area. But ultimately, because of the way in which we perform readiness activities and the challenges of trying to do that sort of operating multiple programs for a one same population at the same time, we feel that this is the least risk. I should say this is the most risk averse approach to do a sort of, I'll call it cutover to this new system with the Pathways program. It's how we've rolled out other managed care programs in the past. To your point, in the reference to Southeast Trans, based on what we've learned from that experience historically, that has completely informed and sort of, I will say, transformed the way that we do readiness activity. And some of the things that Holly has mentioned, we have very stringent requirements on the managed care entities related to that specific rollout and go live. and a lot of protections along the way to ensure that members have a very smooth transition into the program. Holly or Darcy?
That sounds good. Forgive me for interrupting. It sounds good because I want to dominate the conversation because I got a lot of concerns here. Phone calls to elderly people are very difficult. Number one, the cognitive ability of the person on the other end of the phone can always be hard to judge. Number two, there's a lot of hearing loss in this population. They don't catch everything you're saying. And I don't know that phone calls is the way to go. So there needs to be a different plan, or at least an option that people can have a face-to-face, or family member can have a face-to-face. Because what I see, if you flip a switch and there's 150,000 people coming into this plan on July 1st in 3 different, say they each get 50,000, that is, I mean, people are change adverse. I get it. I've done it for a long time now, trying to manage change adverse, but I'm just, these are people's parents. These are people's grandparents. This has the potential. I'm just concerned. You get my drift. I'll be quiet.
And I appreciate your comments. I mean, we are really working collaboratively with our all the AAAs in the state, and we're also working collaboratively with many of the other kind of advocacy groups or associations to make sure that they all have the same information as well that we're sending out to members. We plan to really kind of lean on, for example, the individuals right now that are receiving home and community-based services. They have a case manager that's engaged with them monthly and quarterly. And so we're really going to be leaning on them to help us get these messages out to individuals that they work with. And we're going to be really leaning on our home health and hospice partners to help get the information out to the individuals they, work with. And so Darcy's going to go into some of the communications that we've been doing, but we have ongoing community stakeholder meetings and information webinars that we are doing and gathering feedback and concerns, just like the concern that you've just voiced, so that we can make sure that we're really trying to dot all those I's and cross those T's and make sure that no one day one will lose a benefit or be stuck somewhere that they shouldn't be.
Senator Kadora, did you have a question or just
briefly? I think with the choice program for senior citizens, how does this fit with that? And then what is the current wait list on the choice program?
I don't have the information on the choice program. I will tell you, individuals who receive choice services can also receive be in pathways, and our MCE partners will be getting they will receive like a notification through the enrollment file or one of the supplemental enrollment files that tells them which members also receive choice services. I don't know if you know the number right now currently.
And I would say we're working really closely with the AAAs on that particular issue as well to ensure that we recognize that there's going to need to be some alignment there and, cross sharing of knowledge and the like. So the AAAs are a very embedded partner into the launch of this, and they're a very active stakeholder group that we're working closely with, and that the MCEs are contracting with in order to provide service coordination. So I think to your question, Senator Kadora, being in lockstep with them will really help ensure that we manage those two programs in a way that makes sense collaboratively.
I appreciate that. If you can follow up with me, if you don't mind,
happy to do
maybe
that
via email. I just would like to know, I received a former constituent, my district was redrawn, and a former constituent reached out in the last week and said that 2 of his close friends in the community applied since March of this year, 2023, and were told, he wasn't sure if it was the AAAs or the state, that he was told that the wait list is, he was told it's 2 years. So I'm not sure if that is a misinformation, or if that's the case, what is the issue? Is it a budget issue? Is it lack of available? So if you can just follow up me with some facts that I can share back, that would be helpful.
Absolutely. We're happy to collaborate with our Division of Aging partners and get the specifics on that. We'll follow up with you. Thank you.
Appreciate
for that.
It. Thank you.
Representative Clear.
Thank you. I know we're short on time, so I'll try to be brief, but I appreciate Representative Karakoff raising the Southeast Trans experience as a cautionary tale. As some of you may recall, I've raised that a number of times over the last couple of years, and I appreciate all of the work that has gone into this. I think you all have done tremendous work, and you continue to do tremendous work. But I remain very concerned about the disparity between what I'm hearing from the AAAs and what I'm hearing in this meeting and other meetings. I think this has been driven too much by the MCEs. It's going to be implemented in the last year of a gubernatorial administration, in the second half of the last year of a gubernatorial administration, which is not a good time to implement something like this. I know there's a lot of political pressure to see it implemented within this administration, and I get that, but I'm very concerned about it. And I'm very concerned about what we may be losing. The AAAs depend on case management for a significant portion of their revenue, as most of you are aware. Again, what I'm hearing from the AAAs does not match up with what I'm hearing in this meeting and others. I've raised this in the choice board a number of times. There are still questions that haven't been answered about how the case management or care coordination or whatever we're calling it is going to work with the AAAs. And again, recognizing that they rely so heavily on that reimbursement, I'm thinking even seasonally right now, my AAA is working on angel tree boxes for seniors. I'm afraid that we're going to lose things like that because the MCEs are not going to do angel tree boxes in Southern Indiana. And the AAAs at some point, a couple of years out, may no longer have the revenue from case management to subsidize those other functions. So those other programs like angel tree boxes for seniors who are facing loneliness and isolation, senior games in the summer, all kinds of programs, and those questions continue not to be answered. So I just want to put all that on the record and make sure we're going into this clear-eyed, because I hope it will be successful. I want it to be successful. I am willing to do anything that I can do to help make it successful, but I'm afraid it's going to be a train wreck.
Appreciate the comments. I just want to reiterate. Sorry, go ahead.
I just said ditto.
Oh, ditto. I thought you said veto.
I'd roll call this if I could.
Representative Clear, absolutely hear you on that. And, we at the state have invested a lot of time and will continue to do so in really forging a collaborative relationship with the MCEs and the AAAs and continuing to have that constant feedback loop with the AAAs. So just want to acknowledge your concerns and know that we hear them.
I appreciate that. And again, nothing I said should take away from the work of you and your team. We have a lot of great people at OMPP and FSSA more broadly, including folks in this room. So I appreciate everything you're doing, but I know you can only do so much within the parameters that have been set. So again, not to take away from you or your team, I appreciate you and your team and everything you all are doing.
Understood and appreciate that. Is there someone else? Oh, Darcy. I knew there was something else. Darcy's going to speak a little bit in our last few minutes here about the member communications and some of the things that Holly alluded to here.
Yeah, we'll just move to the next slide.
All right.
Great. So as Holly, oh no, you're fine. You can stay there. As Holly mentioned, members we've identified as moving with us into Pathways on July 1, 2024 will start to receive those notices that say, hey, Pathways is coming in July. Be ready to select a health plan. And when members get those notices, our job at FSSA is to make sure members understand and recognize that language, right? The Pathways language, so that they do select that plan and that they don't just think, right, what they're getting in the mail is junk mail and toss it out. And so to do that, We have been working to really build our capacity around awareness and communication across Indiana. FSSA works directly with a marketing team who helped us do focus groups of individuals in various Indiana communities to find out what kinds of information would be helpful to them and where they like to receive information. And so we also did a commercial. I'm not sure if you've seen it yet. It went live November 1st. And so you will see that commercial on TV. You'll hear about it on the radio. It's also playing, I believe, on YouTube. And we also worked with our marketing firm to create a digital toolkit of information. So brochures, pamphlets, the logo, you can download our PowerPoint template. So if we have advocacy organizations or providers or AAAs who want to share information about pathways with the folks that they serve, they have that material available to them. And we do have some AAAs already who have requested brochures from FSSA so that they can pass them out to members. They seem very engaged in working alongside that member to support them during this process. And you'll notice one of the first ways that we are sharing information is through our new Pathways website, which launched also on November 1st. And I will say that we, prior to the launch of the website, we met with lots of different stakeholder groups, right? Trade associations, advocacy organizations, AAAs, to go through the website and to look at all of the different resources available on the website, because we know that members will be coming to AAAs and their providers because they are a trusted source for those individuals to receive information. And so we want our providers and our AAAs and our independent case management agencies to be armed with information so that when members ask them questions, that they have what they need to be able to answer those questions. Next slide. So on our Pathways website, and you will see if you haven't been to the website yet, there is a link to the website. And I want to point out that we have added a new edition of frequently asked questions documents, both for members and for providers. But what we've learned during this process is that many of our providers seek information from those member FAQs to help answer any questions that they might get from the member. We have specific provider frequently asked questions for HCBS providers because we know that they are new to managed care, and so we want to support them as much as possible. We also have, or will have, almost so close, frequently asked questions for nursing facilities as they move into this program with us. And soon you will see information about continued provider engagement, so helping our HCBS providers develop their business so that they can work with managed care companies, because this will be new to them. We are also doing some targeted work groups with nursing facilities so that they are supported during this transition and looking at alignment across policies and procedures with the MCEs. Yeah, and so I think that's, yep. And so we, on November 1st, the Pathways phone number went live for individuals to call if they have questions. So in the commercial that individuals see on our website, they will see the Pathways phone number, and this will get them to an actual individual if they have questions about the program. OMPP has been working with our vendor Maximus to answer. We have scripts that we've designed to help Maximus answer questions, a standby document for both internal staff and Maximus. And I did want to point out for the previous slide, we will be, you will see information that we will be doing also in-person member engagement in March of 2024. And so FSSA staff will be out in every section of Indiana meeting with individuals. We will have copies of the notices, each notice that someone receives, so that we can, so for members who show up to these events, we can walk them through that notice and make sure they get to where they need to go. We will also have virtual sessions for people who aren't able to attend virtually and work with the AAAs, right, for helping members get connected with technology if they'd like to join, or if their caregiver or their family would like to join. So we will be out meeting with individuals, and then you will see that posted on our website as well, when those dates are and the locations. And then I also wanted to say, if you have you work with anyone who has questions about Pathways, we are keeping or logging those questions and answering them in the backhome.indiana@FSSA inbox. We are also, in addition to answering the question, typically adding that question to the frequently asked questions documents. We have an internal process that we work on to continually update those frequently asked questions so that we stay current with what's happening boots on the ground.
Thank you, Darcy. Any questions about the communications information? Yes, Senator Yoder.
Is it possible to walk through real quickly a role play of what this is going to be? If I am the current person who's going to receive a letter, right? These letters that are going out, I get the letter. I'm lucky. I've opened it. I'm kind of confused. I see that phone number and maybe I call because I don't understand. It's telling me I'm going to have to make a decision with one of the three. So I call the phone number. What happens? So I say, you would say, hello, welcome to Pathways. So I received a letter and I have to make a decision between the three.
And you would say, I'm really confused. I don't know what this means. And so the person, right, answering that phone call is expected and has resources to address those questions, to understand, right, okay, today, right, you work with a AAA. Tomorrow, you are going to work with one of these three insurance companies. And so one of the, in our information sharing sessions with both providers and AAAs, one of the pieces of information that's so important is that they are helping folks identify, right, who is my case manager today? Because if I want to keep my case manager, I need to say to Maximus, right, this is my name, this is my AAA, this is my case manager. Where's my, they may ask, where's my case manager?
Is any of that information going to be on their letter?
So the information that is, there will be targeted letters depending on if you are currently in home and community-based services, right? So if you're currently in home and community-based services, your letter will be directed to you. It does not have your case manager's name in the letter, but it will tell you where to go or who to contact.
Okay, so I contact to find out who my case manager is. At some point, I mean, if what is that person saying? I'm saying I got this letter. I'm being asked to choose one of these three
Part of the
provider.
role of Maximus is to provide education, right? Help them determine which of the three would be a good fit for them.
So I'm asking, which of these three is a good fit for me?
So I would want to ask you, right? I would want to know what services you have today. Who are your providers?
So of the three, there are going to be specific things that each of these provide. And if you make a mistake and choose the wrong one, I mean, what happens?
You don't answer. Yeah.
In the scope of work, we have stated to the MCEs that they have to have an open network for the first 3 years, that they have to contract with any willing provider that wants to contract with them or be in their network. So for the first 3 years, pretty much all of the MCEs should be working with all of the providers, whether they're in network or not in network. Their goal, though, is to get those providers in network. So after the 3-year period is up, then those members that did come to them, they will be able to continue to serve them. So that's the overall goal. So for the first 3 years, really, it will really be your choice. Maybe you're already with United as your D-SNP provider, and you really like what they do. So you're going to go ahead and stay with them for Medicaid and not move both your D-SNP and Medicaid to someone else.
And I would just also share, Senator Yoder, that the plan selection process as a whole is not necessarily unique to Pathways. Of course, we'll have much more plan selection happening because we'll be transitioning so many Medicaid members at once onto the plans. But in our other programs, this same sort of activity already occurs around selecting a managed care entity. So we do have some, I'll call it lived experience to go off of and make sure that our enrollment broker, Maximus, is really prepared to be a partner with the member or their caregiver or their authorized representative. I think maybe because of the time where we are on time, at our February meeting, based on some of the conversation here, we'll plan to provide another update. At that time, we'll be getting ready to kick off and in the midst of some of this. So we can share a lot more detail around the scripts and what type of information and how those conversations are going to play out.
And I will add too, if Maximus cannot answer a question, then they will send that individual's information over to someone at OMPP who will reach back out and work with that individual.
Okay, given where we are on time, I think we'll plan obviously to have another Pathways update at the February meeting. But at this point, I will open it up for comments, starting with MAC members, and then going to if there's anyone for public comment. Representative Clear.
Thank you. Is the chat on the YouTube being monitored?
On the YouTube, the live chat, no, that is not.
I was afraid of that. So I just want to get something onto the record. Tony Gillespie, who does governmental affairs for IMHC, the Indiana Minority Health Coalition, has been on the YouTube feed, and he texted me because he had made comments during the pregnancy piece. And full disclosure, I'm on the board of IMHC, but if I could just briefly put these on the record for response at a future time. Are the services, these are Tony's questions, are the services culturally inclusive and appropriate for racial/ethnic families? With the doula services, it is important to build a reimbursement model that factors in the significant racial/ethnic disparities that impact Black expectant families. What is planned to provide outreach and engagement targeting Black and Brown expectant families? And is there a methadone component with this program? Tony mentioned methadone. I would expand that to MAT broadly. So don't have to address any of those now, but I wanted to get them on the record. And for future meetings, I would suggest we monitor someone monitor the YouTube chat for public comments, or if it's not going to be monitored, if there's a way to turn it off, that it be turned off. But I would prefer to see, members of the public have a way to make comments, even if we don't respond to them within the within the meeting. But thank you.
Sure, we'll follow up on that, and thank you for sharing the specific questions from IMHC. Other comment?
I just had a question regarding an update from legislation that we passed 2 sessions ago in regard to the waiver for Medicaid for the incarcerated and where Medicaid stands, since that is a huge provider gap for us in providing services.
Thanks for that question, Zoe. And certainly want to acknowledge that the justice involved population is an area that, as a Medicaid policy matter, we're monitoring very closely and thinking about strategy and how best to serve that group. So I can quickly respond to that as far as the status of that waiver. We are monitoring what there are a number of other states who have submitted an 1115 waiver or SPA related to this same requirement that is put into legislation a couple of sessions ago. And so we are watching what happens with those states. Particularly Kentucky has submitted one very similar. And our understanding is that CMS is very backlogged in reviewing those. As soon as we see sort of the outcome of that and whether it will be allowable, that's really when we will, go full steam ahead in sort of that next step on that. Thanks for the question.
Thank you.
Other comments? Representative Karakoff? Representative Karakoff, do you have your hand raised for comment?
Yeah, I'm sorry, my mute was on.
Oh, no problem.
Comment, not really a question, but I hope that Maximus and the AAAs recognize that they are your vendor, that they are your de facto employee, and that you're the boss. Because I've had experiences that these folks go out, these organizations, these contractors go out and they perform what they believe they've been contracted to do, and they're pretty rigid. Surveys. I mean, the health department just did a survey that they stick to the script, and the person is trying to have a dialogue with the person reading the script to them. And older people just don't communicate on the web. You get my drift. You're going to have Maximus, AAAs. They're going to have an ability to use common sense and communicate in ways that elderly people understand. And if we're not doing that, I want to be an optimist, not a pessimist, but Representative Clear's right. This is fraught with peril. And I'll get off my soapbox again. I'm sorry.
Understood. Thank you, Representative Karakoff. And your comments are definitely noted, both on the record and amongst the staff here with us today. Seeing no other MAC member comment, is there any public comment? For public comment. Any members of public signing? Okay. And with that, I know we have a number of follow-ups, so we will take those back. Our next meeting, again, now that we have that approved, will take place on Thursday, February 22nd from 1 to 3 here in Conference Room B of the Government Center. And also hybrid format on Zoom. And with that,